Well, I start off with a disadvantage. It's hard to argue with the vice chair of the NCCN panel who stands like this and says, "Go to the website." So instead of saying, no, we shouldn't follow, I would say, yes, we should follow the NCCN guideline, but we can do better. So the NCCN guideline, you just saw it. To me, when I look at this, I see age 45, 75, 75, every 1 to 2 years. I just see everyone being screened all the time. And that is my major concern with this guideline. So how can we improve this? How can we do a more risk-stratified screening? So it ain't what you do, it's the way you do it. And here is our 5 golden rules from the Memorial Sloan Kettering Cancer Center guidelines. Get consent, start these conversations at 45 to 49. You risk stratify and adapt the screening interval according to the man's age, his health, and his prior PSA. Don't screen men who won't benefit. Who are they? Well, limit screening in older men. Stop at 70 for most. And we have this idea about early cessation, and I'll come back to that. Limit screening in men over 60 with a PSA less than 1. Don't biopsy with compelling reasons. We agree with Dr. Crawford and the NCCN guidelines about repeating the PSA workup for benign disease and considering biomarkers. We also don't uncouple screening from treatment, but they're all one. So recommend active surveillance for low-risk tumors and refer men who do need treatment to preferentially high-volume providers because the outcomes are better. And if we put all these 5 golden rules into a model, we can show that, yes, a common practice, which is to screen everyone all the time, every year, is that, yeah, we do save lives, but we also lose quality-adjusted life years by doing so because of the overdiagnosis and overtreatment. So instead, if we follow the 5 golden rules, you get a more favorable balance between the benefits and harms. So let's look at where we agree and where we disagree. Who's a screening candidate? The NCCN guideline says to look at all these factors and basically use clinical judgment. We will definitely agree. What would you say is the most strong risk factor for reducing prostate cancer mortality? Which is the strongest risk factor?
I think you should ask them.
What do you think? Family history? Anything else? Someone else? Lifestyle?
Yeah, obesity.
Mm-hmm. Okay, so that's more primary prevention. A very high PSA. The baseline PSA is actually the strongest risk factor for prostate cancer mortality and provides the most favorable ratio between the number of men you would have to screen and the number of deaths you can avoid as compared to both family history and race. And this is based on all the studies on the baseline PSA testing. What tests should we use? Well, we would say just use a simple blood draw, but the NCCN says also strongly consider the DRE. As we know, the DRE has a poor sensitivity, and there's also, of course, the issue of feasibility and resources. I mean, some primary care physicians say that it takes only 2 minutes to perform, why not do it? But you know, it adds another level of complexity. Definitely as a second-line screening test in men with elevated PSA, we would definitely do a DRE. Age to start, age 45. We can both agree on the age 45, and this comes from the baseline PSA studies. This is, for instance, the Physicians' Health Study, and this is the Malmö Preventive Project from Sweden, where you can see this beautiful separation of risk by your PSA level at age 45. If you want to be more conservative, you can follow the European screening trials that in Göteborg we started at 50, in the RSBC started at 55. Here again, the Malmö Preventive Project at age 50 to 55, showing the benefit of baseline PSA and the risk of future metastases and mortality decades in the future. And again, this is data from the Göteborg trial showing that if you start screening sooner, you can reduce mortality more. You see the relative risk reduction at age 50 is much greater than it is if you were to start at age 55. And when we compared men who were screened in the Göteborg trial to men who were unscreened in a cohort in Malmö in Sweden, we showed that if you start at 50, you can reduce mortality by 71% at 17 years. So if you should start screening, definitely start before 55. So when should you stop? Well, you said the patient advocate didn't want you to stop, so you continue after 75 in very healthy men with little or no comorbidities. And why we say don't screen older men is because you can avoid overdiagnosis by 42% if you stop at 70. So we think having a sensible approach to screening elderly men is preferable. So this should be based on past PSA levels and the health of the man. And over 75, it's not recommended. What about this early cessation? This is a rather bold move to some. The study that we have showing this evidence is a study from the Malmö study where men in Sweden were unscreened and followed for 25 years. And you can see that if your PSA level is below 1 at 60, your risk of metastases and death by age 85 is 0.5% and 0.2% respectively. That's a very low risk. So that means that you can stop screening at age 60 for these men without risking anything bad happening to them in the future. And that's about, it's a large proportion of participants. And similarly, we showed in another cohort from Sweden that continued screening at age 50, 60 should focus on these men who have a PSA in the top quartile, because those are the men who have an increased risk. And when we compared men in Göteborg who were screened to men who were not screened at age 60 in Malmö, we saw that if you were to continue to screen men with a PSA below 2, you would only risk an increase in incidence without any benefit in terms of reduction in metastases and mortality. So that's why we would recommend stopping early if they have a PSA below 1 at age 60. How often should we screen? NCCN says every 2 to 4 years, which comes from the USPC trial, or more frequently if the PSA is between 1 to 3. We don't see the reason for doing that as frequently. We need to have intervals that balances the benefits and harms of screening. So we have those stratified by age groups. If a man is between 45 and 49 and the PSA is between 1 and 3, we say every 2 to 4 years. If it's below 1, we can extend that interval until they're 51 to 55. And the same if they're 50, 59, again, 2 to 4 years. Or if it's less than 1, they can see their primary care provider again at age 60. And here at age 60 to 70 is where the no further screening comes in if men have a PSA less than 1. Otherwise, it's every 2 to 4 years. When to biopsy? NCCN says if the PSA is above 3 or if it's above 4 in the elderly. And also perform a pre-biopsy workup, we agree. And here's where you can do the DRE, repeat the PSA because you remember Dr. Issam's study about how PSA fluctuates, and consider the reflex testing. And we know that use of these reflex tests can reduce unnecessary biopsies by about 50% if you use the free PSA, the PHI, or the 4K score. And this slide keeps, I keep updating this every year. I need to update this slide after this meeting. We used to have only the PSA test, but now we have plenty of more new biomarkers that can help us. We can also use simple risk calculators to determine the need for biopsies, such as the PCPT or other risk calculators that can also give you a % risk. So in summary, we agree with NCCN guideline, but we think we can do it slightly better. And now Dr. Crawford, who's skeptical, will ask me, what about PSA 1.5? Isn't that simpler than both of these algorithms that no one will remember? My answer is that we need to study it. So I applied to the Prevent Cancer Foundation and I got a grant to work with Dr. Keibel, who's a urologist in Boston, and his colleague Dr. Healy, who's a primary care physician. And we're now doing a study where we are developing a decision support tool where we are integrating the NCCN guideline into the medical health record. And we just had a focus group a month ago with some primary care physicians, and they loved it, and they would be very happy to see a tool that can help them give advice to patients when to screen and how often to screen. And now we're studying this in a pilot study to see if it actually improves guideline concordant care. Do we screen those who need to be screened, and do we avoid screening in those who don't need to be screened? That's it. Thank you.